Okay, hello everybody and welcome to this month's IMV Imaging Journal Club. In this month, we're going to be discussing the utility of point-of-care lung ultrasound for monitoring cardiogenic pulmonary edema in dogs. My name's Sam. I'm one of the in-house vets here at IMV Imaging. Before we start, I wanted to just go through again a little bit how our journal club works. So each month we're going to put a presentation of a journal article or a critically appraised topic on our website for everybody to watch. So if you're watching this now, hopefully that's where you found it. You can watch these on demand, and as I said, there's one every month. After the presentation, we'd love for everybody to get involved. So send in your comments or questions to our email address at clinical@imv-imaging.com as well. And then again, after each presentation, the following month, we're going to have an informal live discussion on the research. So again, hopefully, if you stay tuned to our social media or our monthly clinical emailers, you can see when these are coming up and hopefully join in. They're really interesting. We'll often talk around the topic and go into some bits in a bit more depth, as well as sort of talking about any issues we raised in the paper or any questions people have sent in on the back of it. So do get involved as well, and we'll open the chat on the night for the live discussions. And if you want to join us and speak to us, you absolutely can. And if you're interested in about how it works with this sort of CPD side of things, the CPD certificates are given out after attendance at the discussion. So if you watch the presentation, then you come to our live discussions, we'll pop out the CPD certificates after that as well. So this month, I chose to have a look at this paper from this year from the Journal of Veterinary Internal Medicine, which, as I mentioned at the start, is on the utility of point-of-care lung ultrasound for monitoring cardiogenic pulmonary edema in dogs. The paper is open access, I believe, so you hopefully should be able to find it, and then you can have a read through yourself either after the presentation if you want to. So just a bit of an intro to the point-of-care ultrasound itself. So in this specific paper, we're looking at left-sided congestive heart failure in dogs. So left-sided congestive heart failure causes an increase in hydrostatic pressure within the pulmonary vasculature and leads to pulmonary edema. And traditionally, or kind of more generally, currently, diagnosis relies on thoracic radiographs to look for the alveolar pattern we'd associate with pulmonary edema. The thoracic radiographs do have some downsides to them, so they often involve the patients being placed in recumbent positions. They often mean the patients may have to be removed from oxygen cages, and there is risks of misinterpretation, especially when radiographic technique is poorer as well. So there are some downsides to thoracic radiographs for diagnosis. So lung ultrasound has been an effective tool used for the diagnosis of pulmonary edema in people. So it's been used for some time, and that identification is based on identifying B-line artifacts within the pulmonary tissue. So these are discrete, narrow-based, vertical hyperechoic artifacts extending from the lung surface to the far field without fading and moving synchronously with respiration. So I've done a little diagram here on the right just to give an idea of what a B-line artifact might look at. If we imagine we've got our microconvex transducer placed against the thoracic wall at an intercostal space, we might have two ribs kind of bordering that space, creating an acoustic shadowing. So these are the rib shadowing here. And in normal lung, we would often see this these A lines, these equidistant repeating hyperechoic artifacts that we associate with normal lung tissue, whereas B lungs, as you said, are these sort of almost kind of discrete, kind of triangular artifacts extending from the lung surface right through to the far field without fading. So this is an example of what B lines might appear with. And in normal dogs, B lines may occur in 31% of normal dogs, but where you have pulmonary edema or you've got pulmonary contusions or pneumonia, you will get numerous B lines observed in sites from there. So this is what the basis of how we're diagnosing the presence of edema. So in this study, their objective was to investigate the utility of lung ultrasound to monitor the resolution of edema in dogs that have been diagnosed with left-sided congestive heart failure. They wanted to compare lung ultrasound to other methods of assessing the resolution of edema, including thoracic radiographs, observed respiratory rates, and the pro-BNP test as well. And they also looked at the pattern of edema resolution, and they evaluated the ability of ultrasound to predict clinical outcomes, including sort of when there was signs of recurrence of congestive heart failure and a cardiac death. And their hypothesis was that lung ultrasound would be diagnostically useful in monitoring the resolution of congestive heart failure in dogs. So for the paper, what they did is they took client-owned dogs that presented to two veterinary hospitals in the US that came into the emergency or cardiology departments. The dogs were diagnosed with left-sided congestive heart failure based on their clinical examination and history, the echocardiographic exam. So they had an echocardiographic exam performed by a cardiology resident that confirmed that they had myxomatous mitral valve disease or dilated cardiomyopathy. And they also had thoracic radiographs confirming alveolar interstitial pattern consistent with edema. And they also used this sort of response to diuretic therapy as a method of diagnosing as well. Within sort of 6 hours of hospital admission, each of the dogs had to have had a lung ultrasound performed by a trained investigator, 3-view thoracic radiographs, and venous blood sampling for NT-proBNP. And they excluded dogs that had a pleural effusion or dogs that had previous evidence of congestive heart failure or been treated with diuretics prior to coming to the hospital. The reason the pleural effusion was excluded is because the buildup of that fluid around the lungs causes atelectasis, and that would create B-line artifacts within the lungs itself from the presence of the effusion. So that's why they didn't include those patients with effusion. So the dogs in the study received emergency and outpatient therapy as dictated. These were real cases at a hospital that needed treatment. So this was at the discretion of the sort of attending physicians as well. I've just put up a list of the emergency treatment and the outpatient treatment just for interest as well, if you wanted to see what they were using in each of those scenarios. It's quite standard kind of medical therapy that you'd use for managing congestive heart failure and for managing these cases as well. But it's always interesting to see sort of what they used in each sort of scenario. And for each patient, for the study, they identified 4 clinically important time points as well. So they had a time point at initial presentation to the hospital. That was within sort of 6 hours. Within 2 hours of hospital discharge, their sort of first recheck appointment and any subsequent rechecks. So that was time points 1, 2, 3, and 4 respectively. And each time point they aimed to give a physical exam, an ECG, lung ultrasound, thoracic radiographs, the pro-BNP, and the caregiver quality of life survey as well was to be performed at each. There was some minor differences between certain time points in terms of exactly what was done in each case, but generally this is what they aimed for. And as I said, it's important to just note, and we'll come back to this, is that pharmacological treatment for congestive heart failure was permitted before imaging and between imaging studies as well at the discretion of the clinician. So as I said, these were cases coming into the emergency department. So at time for the animals' quality of life and welfare, they needed, of course, to treat their underlying condition before they performed some of these tests or during these diagnostic workups as well. So just focusing a bit more on the lung ultrasound. So the lung ultrasound was performed by a cardiologist or cardiology resident. They used a curvilinear probe of 5 to 8 megahertz frequency and a depth setting of 4 to 6 centimeters. They did a protocol using the VET Blue protocol, if you're familiar with it, which is just using 4 standardized acoustic windows, 1 on each side of the thorax, with the dogs in standing or sternal recumbency. And that made up for a total of 8 sites they performed lung ultrasound at. So they had a left and right caudal, perihilar, middle, and cranial site as well. So that was sort of made up the 8 on each side of the thorax as well. And what they did is they recorded how many B lines they noticed within an intercostal space, depending on the number of them as well. They had 1, 2, 0, 1, 2, 3, greater than 3, or infinite. And infinite was recorded where there was numerous coalescing B lines. So many B lines that they coalesced together, and it wasn't possible to actually individually discern which ones are there. And then they did a sort of scoring system for them based on some consensuses in people as well. So if a site had greater than 3 B lines or infinite B lines, that was sort of noted as a strong positive site. And for scoring, they scored it based on the number of B lines. When you got to above 3, that was given a score of 4. And where there was infinite B lines, that was given a score of 10. So between the 8 sites, that meant there was a maximum score of 80 that a patient could get as well. This little video on the right-hand side is actually just from a position to look at the lung as well. So this is the glide sign that people talk about as well when they're examining lung, which is this artifact, this sort of formation created by the sliding of the parietal and pleural the parietal and pulmonary pleura sliding against each other, so you can see this glide sign. Something we talk about a lot in relation to the diagnosis of pneumothorax, but I thought it was good to kind of pop that video in just as a nice example, just showing some lung ultrasound taking place as well. For the lung thoracic radiography, they did 3-view thoracic radiographs that were analysed by a single board-certified radiologist. They did do a scoring system for them, and this was based on their DV, the dorsoventral view. So they basically divided a vertical line running along the spine from the thoracic inlet through the middle of the thorax, and then they did a perpendicular line through the region of the carina and the chest as well. So this created 4 quadrants, sort of left and right cranial and caudal quadrant as well. And then they scored them based on the sort of infiltrates, so this sort of alveolar interstitial pattern present and how much of the area was affected by it in each quadrant. So a score of 0 for none, 1 for less than 25%, 2 for 25 to 50, 3 for 50 to 75, and a score of 4 was 75 to 100. So you could get a maximum score of 16 for the lung quadrants as well. So in the study, there was 25 dogs that met the criteria. It's quite a small study. Of those, 15 of them had myxomatous mitral valve disease and 10 had dilated cardiomyopathy. At the first time point, every single dog had at least one strong positive lung ultrasound site, so one site that they saw more than 3 B lines or infinite B lines present. They noticed that over time, between the time points, and especially between time point 1 at admission and time point 2 at discharge, there was a reduction in B lines of 87% noted as well. So just showing the sort of effectiveness of the therapy that they were given. Something just worth noting on the results, as I mentioned before, is that actually 19 of the dogs had received a dose of furosemide prior to any imaging studies, and a further 6 had received doses between imaging studies. So again, we'll come back to this in a little bit. And they saw that the thoracic radiograph edema score decreased at time point 2 and time point 3. So it's just a highlight of some of the results. I also have put up the table just showing the results and the statistical significance, comparing some of the time points as well, which is just quite interesting because this summarises a lot of the changes over the time through the dogs that they observed in the studies as well. So just some kind of interesting kind of points to put on there. Something you can see that over time at admission at the hospital, the respiratory rate was quite high, but there was a statistically significant decrease in the breathing rate at time points sort of 2 and time points 3. So we can see again the effect of the therapy that was given as well. The heart rate decreased over the time points. And again, looking at our scoring system, so if we look at our B-line score on lung ultrasound, we can see a statistically significant decrease again at time point 2 and time point 3. Similarly, for the strong positive sites, there is a statistically significant decrease in those as well. And similarly for the edema score seen on thoracic radiographs as well. Interestingly, the pro-BNP, where they sort of took that, there was a decrease in pro-BNP that was significant between time point 1 and time point 2, but by time point 3, that had returned to a level similar to that of time point 1 again as well. And possibly not surprisingly, there was an improvement in quality of life with the dogs that were treated. So it's just a good summary of the results, and that's taken directly from the paper itself. So again, continuing with those, so there's a good reduction in B lines and strong positive sites for all 8 sites between time point 1 and time point 2. At time point 1, the thoracic radiographs seem to suggest more severe edema within the right lung with a higher median edema scores in the right quadrants compared to the left. So it seemed to be that with in the initial time point with thoracic radiography, there was a difference in the distribution, whereas with lung ultrasound that wasn't observed. It was similar between sites as well. Of the dogs in the study, 7 had recurrence of congestive heart failure, and that was picked up at their further visits at time point 3 and beyond as well. Something that was quite interesting, they picked up that at home, median respiratory rates measured before visit were significantly higher for dogs found to have controlled congestive heart failure. So this was something that was very useful for monitoring for the recurrence of congestive heart failure in patients. So whereas the dogs that were uncontrolled had an average of 36 breaths per minute, those that were controlled had an average of 26 as well. So that was, again, I'll come back to mentioning this, just the utility of these at-home measured respiratory rates for looking for signs of recurrence. And of the patients in the study, the only significant predictor of negative outcome at 90 days in regression analysis at from time point 1 variables was a higher thoracic radiograph edema score. So the only thing out of the variables they looked at which seemed to to predict a negative outcome was how bad the edema was on the thoracic x-rays. So what this sort of study, just kind of looking at this kind of discussion from it, we showed that the lung ultrasound indices in dogs, i.e. the number of B lines and the number of strong positive sites, improved from initial diagnosis of congestive heart failure to discharge as well. So it shows that these indices, the positive sites and the score, perform very well for the purpose of monitoring edema resolution as well, and that the B-line artifacts improve quickly with therapy and they track with the thoracic radiographs and clinician-assessed clinical improvement, so assessment of the patients, both their caregiver quality of life surveys and their respiratory rate, etc. as well. Similarly, the thoracic edema scores improved from initial congestive heart failure diagnosis to discharge as well. And as I mentioned just previously, the owner-assessed at-home respiratory rate was the best indicator of congestive heart failure control. So that was the best thing that owners could do for monitoring for potential recurrence of congestive heart failure. And the in-hospital respiratory rate did not vary based on how well controlled their congestive heart failure was. So it just shows the effects of sort of white coat syndrome and stress. The pro-BNP, as I mentioned, at the first sort of recheck, that had increased to levels similar to the initial diagnosis. So it's just showing that for monitoring for recurrence of congestive heart failure, pro-BNP isn't that useful, really. So it's not as effective for gauging control compared to the diagnostic tests of radiography or lung ultrasound as well. There was a number of limitations with the study. It is very small, so it's only 25 dogs in the study. So it is a quite small study. The images were all associated with specialists, so often quite a common thing that's noted as a limitation. A lot of these studies of imaging is that they are performed with specialists, and then it's harder to gauge whether the same sort of test would have the same utility when used by general practitioners. Saying that, they flag up in the study as well that some other studies that have looked at it saying that there was sort of a good agreement between sort of specialists and kind of non-specialists when they're using some of these methods. Yes, in the study, the timing of imaging studies varied significantly because these were real cases in a hospital. There was a big variation between when some of these tests were done, and in the same sort of vein, there was a big variation in how when diuretic treatment was given. So it definitely could be an effect of that treatment on the correlation between the modalities, because some had thoracic radiographs done, then got diuretics, then had lung ultrasound, etc. as well. And as I said, this paper assessed lung ultrasound alongside thoracic radiographs. It wasn't assessing it, the utility of it alone, but they were using thoracic radiographs for comparison. So just the kind of the clinically relevant parts of this, I kind of agree with what they've said in the paper that lung ultrasound seemed to be a practical alternative to thoracic radiographs in monitoring the resolution and recurrence of pulmonary edema. I don't think, as I said, the thoracic radiographs are still, as they showed in the paper, are still useful, but given those limitations we stated at the start, if you've got a patient in a hospital setting that's maybe had an initial workup, lung ultrasound does offer a practical alternative for monitoring the resolution and for monitoring recurrence, sort of following that initial diagnosis as well. So it definitely seems effective, and by observing those B lines and observing the reduction in them, you can get a good idea of the effect of that therapy is having within the presence of pulmonary edema as well. And as I said, that's what we've seen in the paper, that lung ultrasound tracks well with these thoracic radiography scores and the improvements in respiratory rates, and it's better than pro-BNP. So as I said, although pro-BNP has utility in other situations, it's shown that it's maybe not that useful for monitoring for the actual resolution or recurrence of edema in these congestive heart failure cases. Something that also was quite strong in the paper was just the utility of owner-assessed at-home respiratory rates. This is something I've seen brought up before with regards to other cardiac case management and other papers as well. So it's something that people might be using, but if you're not, it's something to definitely think about discussing with your owners in patients who do have congestive heart failure, is using that respiratory rate for monitoring. And just as a side, I popped a little video in of my own dog just sleeping in his bed, and just to sort of show the respiratory rate as well, just for monitoring at home. So that's it. That was a brief run through of the paper. I hope you found it interesting. If you have any of your own comments or you have your own questions on it, we'd love to hear from you. You can get in touch with us at clinical@imv-imaging.com, and keep an eye out on our social media groups and our newsletters for our live discussions as well. We'd love to see everybody there, and hopefully you can join us. As I mentioned, my name is Sam. I'm one of the vets here at IMV, and I will see you later. Goodbye.